Today, we're going to follow the entire journey of a broken leg, and not just any broken leg, but a tibial fracture. It's one of the most common serious injuries you can get, and its story is, well, surprisingly complex. It stretches all the way from that initial awful snap to what life is actually like nearly 2 decades later. And to kick things off, let's start with a really crucial fact. The tibia, your shin bone, is the most frequently fractured long bone in the entire human body. So this isn't some rare thing, it affects a huge range of people, which is exactly why understanding this journey is so important. So, our journey starts with the break itself. Who's most at risk here? And what kind of forces are we talking about that are powerful enough to snap the strongest bone in your lower leg? What's pretty fascinating about this injury is who it affects and how. It has what doctors call a bimodal distribution, which is just a fancy way of saying it peaks in two very different groups. For younger people, it usually takes a massive amount of force. Think a car crash or a bad sports injury. But for the elderly, where bones can be less dense, a simple fall from standing height can be enough to cause the exact same devastating break. Okay, so the injuries happened. The next stop on this journey is, of course, the emergency room. This is where the real detective work begins, figuring out exactly what's gone wrong inside the leg. Usually, the signs are, well, they're impossible to ignore. The patient has immediate, severe pain. They absolutely cannot put any weight on their leg. A lot of the time, you can literally see that the leg is deformed or unstable. And in the worst cases, the bone itself might be pushing out or have even broken right through the skin. And that loss of feeling in the foot, that's a huge red flag that nerves might be involved. And this brings us to a really, really critical distinction. In a closed fracture, the skin is still intact. But in an open fracture, sometimes called a compound fracture, that bone has punched right through the skin. This isn't just about how it looks. An open fracture is a game changer because it creates a direct highway for bacteria to get from the outside world straight to the bone, which dramatically, and I mean dramatically, raises the risk of a serious infection. Not all breaks are created equal. The pattern of the fracture actually tells a story about the force that caused it. A direct blow might cause a clean, straight-across transverse break. An angled force, that'll create an oblique fracture. A twisting motion can cause a spiral fracture that literally wraps around the bone, kind of like the stripes on a candy cane. And those really high-energy impacts, they can cause a comminuted fracture, which is where the bone just shatters into multiple pieces. So once the doctors understand the break, the next massive question is, how do we fix it? And this is where the patient's journey can fork onto two very different paths: surgery or no surgery. The decision really just boils down to one word: stability. If the fracture is closed, it's stable, and the bone pieces are still mostly lined up and touching, a doctor might be able to get away with just a cast. But for pretty much everything else, open fractures that have to be cleaned, unstable breaks, or bones that have shattered, surgery becomes the only real choice to get that bone aligned and stabilized so it has a fighting chance to heal. So let's talk about the most common surgical fix. It's called intramedullary nailing. I want you to think of your tibia like a hollow tube. What surgeons do is they insert a strong metal rod, usually titanium, right down the hollow center of that tube, passing it right across the fracture line. It's basically an internal splint. Then they put screws at the top and bottom to lock that rod into place, creating this super rigid structure that holds the bone perfectly still while it heals. But that rod isn't the only tool in the toolbox. If the fracture line runs right up into the knee or down into the ankle joint, surgeons will often use plates and screws on the outside of the bone to piece it all back together. And for the most extreme injuries with major skin and muscle damage, they might use an external fixator. That's a metal frame that sits outside the leg with pins going into the bone to hold everything stable while the soft tissues get a chance to heal. Okay, the bone is set. You'd think the hard part is over, right? Well, not exactly. The journey is far from over. Recovery is a long, challenging process, and it is filled with its own set of potential hurdles. Healing tends to follow a general roadmap. After the first few weeks of being completely immobilized, patients start that slow, tedious process of putting weight on the leg again, usually with crutches or a walker. On average, you're looking at about 4 to 6 months for the bone to fully heal. But for those complex, open fractures, that timeline can stretch out much, much longer. Now, we have to talk about one of the most feared complications of this injury. It's called acute compartment syndrome, and it is a true surgical emergency. Basically, the swelling from the injury can cause the pressure inside the muscle compartments of the lower leg to just skyrocket, and that pressure chokes off the blood supply. If a surgeon doesn't relieve that pressure immediately with a procedure called a fasciotomy, it can cause the muscle and nerve tissue to literally die. It's incredibly serious. And believe it or not, the risks don't stop there. Infection is this constant threat, especially with open fractures. Sometimes the bone just decides to heal very slowly. That's called a delayed union, or it just fails to heal at all, a non-union. It can also heal in the wrong position, which we call a malunion. And even after a perfectly successful surgery, a lot of patients who get that titanium rod complain about persistent knee pain right where the rod was inserted. So this brings us to the final and I think the most revealing part of our journey. What does life really look like? Not just months, but years, even decades after the injury. Well, one remarkable study followed patients for an average of 17 years, and frankly, the results are pretty sobering. It's just startling to see. Even 17 years down the road, fewer than half of the patients were completely free of discomfort. The majority, 53%, still had persistent issues, some in their knee, some in their ankle, and some in both. This really drives home the point that the impact of the injury doesn't just disappear when the bone heals on an X-ray. The fracture also had a profound effect on people's lives and their jobs. Think about this. 1 in every 4 patients was never able to return to the job they had before they got hurt. For a lot of people, this meant a total career change, or taking early retirement, or just being unable to work at all because of their ongoing disability. And this is perhaps the most shocking statistic of all. The crude mortality rate at 17 years was over 37%. And for elderly patients, the risk is especially high. Their 1-year mortality rate is actually similar to that of a hip fracture. It just goes to show that a tibial fracture, especially in an older person, isn't just a broken bone. It's a massive, systemic event that can seriously impact long-term survival. So, what's the key takeaway from all of this? This quote from the landmark LEAP study really says it all. In the end, the fate of the limb often depends less on the broken bone and more on the damage to all the stuff around it, the muscles, the skin, the blood vessels, the soft tissue envelope, that's everything. Which leaves us with this final, really challenging question. For these truly catastrophic injuries, the choice isn't always simple. How do doctors and patients weigh that heroic effort to save a leg against the very real potential for years of pain, complications, and a lower quality of life? It's a dilemma that sits at the very heart of trauma care.